So thank you very much for coming on behalf of the BC Pediatrics Society. I'm now going to introduce Dr. Jane Finley, who is going to do our real introductions. Okay. Thank you, Jane, and then we'll go from there.
All right, where do you want me? Just here?
Yep.
Okay. Well, it's a pleasure to introduce Dr. Earl Rubin, who is born, bred, trained, and remains in Montreal. So Dr. Rubin is triply trained in general pediatrics, pediatric infectious diseases, and medical microbiology, and functions in all three. You do CTU and ID attending and works in the microlab as well. So a very well-rounded person. So I learned a few little things because the bio didn't come from Stephanie for a while, so I've got some stuff off the internet. And I learned that you have 3 fantastic children.
I do. That's on the internet?
That's on the internet. And on Rate MD, Rate My Doctor, scored 4.9 out of 5.
Oh, wow.
And the quote I like, "A great doctor. I feel lucky to have him care for my child. They don't make doctors like this very often." So I give you Dr. Rubin.
Go on that website.
So congratulations and
Thank you.
for coming.
Thank you very much. So I have a ton of slides, and I want to apologize at the beginning in terms of the number of slides, and there'll be a whole bunch of ones that are just graphic, not very graphic, but has graphs, that I will fly through. There's also a ton of information that I've been asked to cover, and then we'll kind of feel it out of what people want to hear. So the evening will be divided in 2. The first will be the invasive pneumococcal disease, and then we'll go to invasive meningococcal disease. And in terms of invasive pneumococcal disease, it's a very controversial hot topic in Quebec. Quebec is always different. We will be the first jurisdiction in North America to go back from Prevnar 13 to PCV10 or Synflorix, which is why are we doing that? And we'll kind of cover the rationale of why they looked at it and where we're going from that. So before we go into all of that, so my conflicts of interest is that I've sat on different advisory boards. So pneumococcal vaccination, Hib was the major player until the late 80s, early 90s, for which we then had the conjugate vaccine, and Hib fell away and pneumococcal disease became the next big problem to tackle. These are numbers from the States at the time before Prevnar came around in terms of the number of cases of meningitis, bacteremia, pneumonia, etc. But the highest attack rate was in infants under the age of 2. So for this part of the talk, the objectives will be to review the different vaccines, whether it's the old Prevnar 7 Synflorix, which is PCV10, or PCV13, which is Prevnar 13. So to be politically correct, I'm going to be referring to PCV7, 10, and 13 rather than using trade names. We'll look at the review of the impact of the immunization program, and then look at the current challenges, predominantly what's going on in Quebec, and whether or not that will kind of trickle outside of Quebec to the rest of the country. So there's 92 serotypes in Canada. There's 50 that are identified every year. 15 cause the majority of the disease, and out of that 15, 13 are obviously in the PCV13. There's the polysaccharide vaccine, which we call Pneumovax, which has 23 strains. So in terms of the disease itself, just very quickly, anywhere between 20 and 60% of healthy children will be colonized with pneumococcus. In the adult world, although it's falling out of favor, there's the urinary antigen for pneumonia to help in the diagnosis. In kids, that just doesn't help because more than half of the kids could be colonized and have a positive urinary antigen. Of those asymptomatically colonized kids, a very small percentage will get invasive disease. Bacteremia by far is the most common. Then there's the meningitis and pneumonia. And there is a seasonal variation, most common in winter and spring. And that is probably due to the fact that It's spread by direct oral contact and droplets, and it's increased susceptibility during viral season. Same thing for meningococcus. It will compromise the integrity of the respiratory epithelium and allow people who are colonized for it to invade if they're not immune. Very short incubation period. And this from 2014, still close to 90% of the invasive disease is bacteremia alone. For those of us that have been around for a while, what I do remember a lot as a pediatric resident and as an ID fellow, and then less so afterwards, is those kids who would come into the emergency room with fever, get a CBC of blood culture, get sent home, get called back because their blood culture was positive. They come back, they're afebrile, the repeat blood culture is negative. I just don't see that anymore. It's very rare. The ones that we do see, where is the kids who are sick enough when they are called back or they're admitted with empyemas and the meningitis and a bacteremia that did not spontaneously resolve. I don't know what other people's impression is in terms of the spontaneous resolution of the pneumococcal bacteremia. Do you still see that? Anybody seeing that? It really has kind of fallen away, but our numbers of hospitalized kids are still there. And so who's at high risk? Sickle cell, asplenics, for whatever reason. HIV, again, we're seeing it was a big issue pre-heart, but now that we rarely see the kids who are true AIDS at increased risk, with the exception of our new influx of immigrants and refugees. Presumed high risk congenital immunodeficiency, but chronic disease, whether it be lung, cardiac, renal, etc. But the major issue is age. And so at the moderate risk, not considered high risk, is those kids under the age of 2 or 3. And that's really who vaccination is targeted for. So if we're going to talk about the vaccines, we have to mention a little bit about the polysaccharide vaccine. In 1977, there was first a 14-valent vaccine, and in the it should be 1982, not 92, there was the 23-valent vaccine. And the studies of effectiveness in adults range anywhere from 0 to 70%. So not a great vaccine. Certainly not a great vaccine for kids. So the younger you are, the immunogenicity is quite poor. There's really no protection in kids under the age of 9 months, and it increases with age, and that we will give it to high-risk kids over the age of 2. But even between 2 and 5, it's not great. It kind of gets better over the age of 5. So what about the conjugate vaccines? So I think everybody here knows the difference between polysaccharide and conjugate vaccines. It's conjugated to a carrier protein. Increases immunogenicity, and that people start to really understand conjugation with the Hib vaccine. First, there was the polysaccharide vaccine in the mid to late 80s, which we were only able to give at 15 to 18 months, 2 years, depending on what year you looked at. But with the conjugation to a carrier protein, we were able to give it to in the first year of life with a good immunogenicity. So Prevnar, whether it's Prevnar 7 or 13, the carrier protein is something called the CRM197. It's a non-toxic diphtheria toxin, versus Synflorix, or PCV10, is conjugated to surface protein of a non-typable Haemophilus. And the concept there, at least for the manufacturer of this, is that hopefully gave cross protection in terms of otitis media, and whether or not that's true is debatable. So when we look at the 3 different conjugate vaccines, there was the original Prevnar, or PCV7. Synflorix, or PCV10, adds 3 more strains, so the 1, 5, and 7F, and 7 was really a predominant player between PCV7 and 10. And then PCV13 adds on top of the PCV10 serotypes 3, 6A, and 19A. And that's really what we're going to focus on, because there is no more regular Prevnar or PCV7, but there is PCV10 and PCV13. So the two, between those two, it's serotypes 3, 6A, and 19A. So in terms of introduction of funding for the vaccine, every province started at a different time. It was available, PCV7 was available on the market between 2001 and 2002, and most provinces introduced it, rolled it out starting in 2002 and to 2006. PCV10 came around in 2009. Most provinces, not most, I would say, I think it's a minority of provinces that started to use it, but the majority did not use it for very long, 6 months or less, because as soon as PCV13 or Prevnar 13 came around, every province switched, with the exception of Quebec and Newfoundland Labrador, where in Quebec we had Synflorix or PCV10 for 2 years. We were the last to introduce it and got publicly funded in January 2011, whereas everybody else kind of started in 2010. So if we look between, so it's a nationally notifiable disease since 2000, so really robust data from 2000 forward. If we look at the time between the introduction of PCV7, or regular Prevnar, in 2002, to 2010 or 2011 when Synflorix and Prevnar 13 came around. So after the introduction of PCV7, the strains incorporated in the PCV7 were the minority of our invasive disease. It was the PCV13 strains between 7 and 13 that accounted for the majority. And so this is from Jim Kellner's group that basically is just very graphically and quickly. Does this show? Do you see my pointer there?
Yeah, we do.
The rapid, so here's 2002, when it kind of gets introduced, and you see that the strains that are incorporated in PCV7, there's a dramatic decline. So in that changing over, we saw a decrease in all the strains that were incorporated in PCV7, but there was now replacement. Replacement, whether it be colonization, which will then predispose to invasive disease, and the two strains that were most common were 7 and 19A. So 7, if you remember, got now introduced in Synflorix or PCV10, but 19A is only in PCV13. So PCV10 gets introduced in 2009. It adds 1, 5, and 7. Quebec and Newfoundland stuck with it for a period of time. And PCV13 or Prevnar 13 gets introduced in 2010. And they're adding now 3, 6A, and 19A. And we already talked about Quebec being the last. So again, graphically and quickly, during the time period that PCV7 from 2001 to 2002, when it starts to get paid for, you see this nice decline, and then a little bit of an eke up, and then this PHID is your surface protein from Haemophilus influenza. Or Synflorix or PCV10, whatever you want to call it, gets introduced here, and then 2010 PCV13, and you see a nice decline overall. This is not just the strains that are incorporated within the vaccine, but invasive pneumococcal disease in general. So Canada, there is a new one that's in 2016 that I didn't have access to all the data in terms of graphs, but things haven't changed significantly. So these next few slides are graphs from Health Canada. And what I want to kind of point out again, so this is now from 2010 to 2014. This is when PCV 13 kind of came in. This red dotted line is kids under the age of 2, which is really the population that we are targeting to vaccinate. So those that are vaccinated, you see a nice sharp decline in the kids under the age of 2. Overall, for all other age ranges, you see this trend downward, but it's nowhere near as significant as the population to which we are directly vaccinating. But other age groups, there is an effect, but not as dramatic. I'll skip over that. So in terms of conjugated pneumococcal vaccine, all pre-marketing studies were done with a schedule of what I'm going to call from this point forward a 3+1 schedule. So it's priming in the first year of life at 2, 4, and 6. In certain places in Europe, it could be 1, 3, 5. It's basically 2 months apart, but 3 doses within the first 6 months of life. So that's, and all the pre-marketing and then subsequent licensure is based on pre-marketing, is looking at a 3+1 schedule. So 2, 4, 6 with a boost at 12 to 15. But that things have changed. So that was 3+1. Then it went down to 2+1. And now there's even a hint of going to 1+1. So everybody understands. So 2+1 is now 2 doses within that first month of life and a booster in the second year of life. 1+1 is only 1 dose. And so, and why is anybody interested in decreasing the number of doses? It's all dollars and cents. So pre-marketing 3+1, post-marketing was 2+1. If you look at the product insert for Prevnar 13, they'll basically tell you when you start with one vaccine, you should continue with that same vaccine. And what led to the 2+1 was the shortage. I don't think it was Pfizer who was making it. It was Wyatt initially when it came out that there was a shortage in the States. And so they had decided that it's much better to still vaccinate everybody, but with less number of doses rather than just giving the proper number of doses and leaving other people out. So they went to a 2+1. Kaiser Permanente looked at that in California, published saying that we have decent efficacy with the 2+1. Quebec, and you'll see that as a theme of this talk, always likes to do something different, whether it's our language separation or whatever. But Quebec said, hey, if it's good enough for the people in the States, it's good enough for us. And they were the first to start with the 2+1, and every province followed afterwards. But so that's the 2+1. But there's there is this paper that looks at the literature review of all the different dosing schedules. So there are schedules that don't have the +1, meaning schedules only with 2 or 3 doses within the first year of life. So that would be 2+0 or 3+0. So just the ongoing theme of understanding what I'm trying to say in all these slides. So this literature review looked at all the different schedules, 2+1, 3+1, 2+0, 3+0, and it would just kind of make sense. The more number of doses that you give, the better it is. And certainly what's essential is to have at least 1 dose in the second year of life. So 3+0 is better than 2+0, but 2+1 and 3+1 are better than the 3+0, and 3+1 is better than 2+1. Basically, bottom line, more doses, the better. In Australia, they initially only did a 3+0, so 2, 4, 6 months, and they saw an increasing incidence of invasive pneumococcal disease over a year of age. So they changed to a 2+1, which they give it 2, 4, and 12, except if they are high risk, and then they do a 3+1. But people are looking, as we're having a good vaccination program with a decrease, as you saw in all the graphs, of the pure number of cases? Can we effectively have the same effect with less doses because it's more cost efficient? And that really is the impetus that is causing the change. So in the UK, there's this guy Goldblatt who is looking at a 1+1 schedule. And the concept there is that there's going to be herd immunity. If you have a good vaccine program with good uptake and a decrease in the number of cases and colonization, then it's a good time to change, not to introduce it as a 1+1, but to change over from a robust program to a 1+1. And again, the impetus to do that is just cost savings. It's a lot cheaper to give less doses. And so here they looked at their 1+1 was giving the first one and only dose at 3 months and a dose at 12 months. But basically, it really gives a period of time between 4 months or even a little bit later, because there's going to be a bump in the immunogenicity initially for a month or two, and then it will fall off. So you have these kids between starting, let's say, at 4 months to 12 months who are at higher risk. And he's hoping that if there's good herd immunity, yes, they're at higher risk, but the herd immunity should protect them. Goldblatt's study has 200 kids in it, 100 in each arm. It's not really enough to say enough. So there's the old ways and the new ways, that they're 1+1, maybe it's coming. But what really is kind of my interest now is what's coming to Quebec. So the CIQ is the Committee on Immunization in Quebec, Comité d'Immunisation du Québec. And they are the committee that gets together. It's made up predominantly of epidemiologists, public health, and infectious disease. They have a very strong voice. They have the minister's ear. Whatever they say, the ministry will do. It's not always the same in every province. But the SIC decided to look at all of this with all this data because they like to do something different. And they were motivated, and for the last 2-3 years, there's been rumblings about, we want a mixed schedule. We want to kind of combine PCV10, PCV13, and they've been talking about that for the last couple of years. So if you want to do that, you have to ask the question, are the vaccines interchangeable? So the first question is, are they equivalent? And if they're equivalent, can you interchange them? So what are the studies that support interchangeability? So this was presented at ID Week last year. And basically they looked at 2 doses. So when I'm going to talk about priming, it's again doses given in the first year of life versus the booster. So here they looked at either 1 or 2 doses of, whether it's 10, 2 doses of 10, 1 dose of 10, 1 dose of 13, whatever the priming is, and then they boost it with PCV10. And they basically said it's non-inferior to the 2+1 of 10. So they're saying it's that first inkling that it's interchangeable, but it doesn't address the strains that are, so the 3, 6, and 19A between 10 and 13. So there's a whole bunch of other studies, and I'm just going to quickly go through it, that have looked at different combinations. So priming with 13 and 10, but now boosting with 13. So that previous slide was boosting with 10. Now it's basically the same study, combination of 10 and 13 in your priming, but boosting with 13. And it's saying that there was a similar response, including 19A, whether you're primed with 10 or 13, as long as you're boosted with 13. But they're looking at this 1 month post-booster. When you look at the data 12 months post-booster, it's not as robust. It doesn't reach the non-inferiority that they had seen 1 month post-booster. But it's basically their conclusion was if you boost with 13, that supports interchangeability. It's going to give you 19A protection. And that was the first inkling that maybe this is the way to go. 3 separate publications question interchangeability, basically looking at different parameters as your surrogate marker for protectivity, whether it's your antibody level, but here they looked at blood memory B cells to assess which is responsible for producing the antibody. So there is still this question about interchangeability. When you want to now compare head-to-head, priming with 13 and boosting now either with 10 or 13, bottom line is that 13, if you boost with 13, it's better. But the question is, how much better does it have to be to justify the increased cost from a public health perspective? So I don't think that anybody can stand up to any of us and convince us that 10 is going to be better than 13. The decreased number of doses is going to be better than an increased number of doses. The question is, what's good enough in terms of the number of cases, public health dollars that are limited? What do we need to do? So Quebec took advantage, like they always do. They do things that are different. And on the CIQ, they have an epidemiologist who absolutely loves to study the effects of what they're doing and then publish. And here what they did is they decided we have a great retrospective cohort to look at because we have PCV7 that gets funded in December 2004, June 2009 we have PCV10 or Synflorix, and January 2011 we have PCV13. And so we can now look back at the kids in these different eras and seeing what is the efficacy. And they basically came to the conclusion that the efficacy was about the same in terms of vaccine effectiveness, between 85 and 90%, whether you got all PCV10, all PCV13, or a mixed schedule. So they're saying based on that, there is this cross protection between 19B and 19A, and that this is a good way to go. So they use their own data to then move themselves forward to say, can we go to a mixed schedule? And that's what's been happening in Quebec. So the question, interchangeability, there's evidence to support it, but there are some questions, and for sure it seems better if you're going to go with a mixed schedule that you at least want to boost with 13 in that second year of life. So although Quebecers may think they are the center of the world, there are other places that do different things. So there is this study from Sweden for which the journal, Clinical Infectious Disease Journal, has published something saying that there is something coming. This is already a published study, but then they put out a warning that the authors are reanalyzing this because there's some question. So that has not yet come out, so I can't tell you what their conclusion will be. But the initial one was what they had done in Sweden is that it's one country, but different counties. And some counties went with a PCV10 program, and other counties went with a PCV13 program. And they wanted to now saying that people from Sweden are all the same. Doesn't matter if you're from the same, a different county or not. And we can now, within this country, have a comparison. And they found that overall, the rate of invasive pneumococcal disease decreased significantly in all counties. There was this suggestion that the 19A herd immunity that was being carried over to the older population, high-risk population, elderly population, was not as good in the counties that got the PCV10 than the PCV13. But overall, they were saying there was some equivalence. And so Quebec now looked at their own data. They looked at the Swedish data. Actually, I thought my next slide was going to be Quebec, but Brazil basically only does 10. And with that, they say there's good effectiveness, but there still is the increased number of 3 and 19A because they don't use the PCV13. So Quebec always has a history of being either, I don't know if you want to call it innovative or controversial. We have our share of controversy. I don't know if you get the same news here that we get at home. It's illegal now to say bonjour, hi. You can only say bonjour when you walk into a store. It's illegal. The whole issue of stop signs, you go to France, it says stop in a lot of places. So in Quebec, it was arrête stop. Now it's just arrête. Inside-outside law, depending on how many employees you have, it has to be French on the outside. So Tim Hortons became Chez Tim Horton. And then there was our whole issue of the multiculturalism, and that, I don't know, again, if that reaches the news here, but the Quebec government had decided that you couldn't have any religious connotations if you worked in the public sphere. So no kippas if you were Jewish, no head, whatever, Sikh, otherwise. You can't do any of that. No, you're allowed to wear a small cross, but you're not allowed to wear not a Magen David or anything else. It was quite controversial, and that kind of got turned down. Pastegate, did you hear about Pastegate? That we weren't allowed to call it pasta, even though it was more Italian and coming from Italy, that they had to take the word pasta off menus. That also got squashed. But we're quite...
What else do you call it?
They pat something. It was a whole... Quebec always tries to be different. So what did our SIC say? So if you look at Quebec data, and again, this is just looking at the same kind of graphs that we had before, the big decrease in numbers with PCV13. This solid line is, again, I'm focusing on the kids under the age of 2 because that's where we vaccinate, right? At 2, 4, and 12 months. And so a nice decrease, PCV13 gets introduced. So here, over here is 10, 13 comes in, there is a blip, and then starts to come back down. So that's basically our history in Quebec. And again, this is just another way of breaking it down by age, over 5 and over 65, and with the different periods. So just a different slide showing the exact same thing, with this solid line being the kids under the age of 5. Here's that same blip that we saw on the previous slide. But when you look at the other age range, not a significant difference. Whereas the other slide that I showed you, there was a nice downward trend. In Quebec, not so much. And again, just more slides showing the same thing. So Quebec was the last to change to PCV13. And lo and behold, we will be the first to go back to PCV10. So the CIQ reviewed the literature, which is the stuff that maybe they had other things, but this is what I was able to find, which I presented to you. And they came to the conclusion that the best way to go is a 2+1, but make the 1 the booster PCV13. So based on that data, with a $20 difference per dose and 86,000 births per year, they can save anywhere between $1 and $5 million, depending on how many doses we're looking at. And they said this because although PCV13 can be more efficient in decreasing invasive pneumococcal disease, the numbers do not justify the cost. It's not statistically significant in terms of the numbers. That if they went with the mixed schedule, for those of us, and I include myself in that, who are skeptical about this, that they'll appease the people who are worried about dropping PCV13 because of the 19A. So saying that there's going to be herd immunity, don't really worry, but we're still going to give it to you at 12 months. They say, and it's the only place that I've seen it, and I don't know if anybody else has this experience, but they say that PCV10 is less reactogenic than PCV13. My experience is that PCV13 is not that reactogenic, but they said that PCV10 is less reactogenic, and maybe there's going to be this increased protection in terms of acute otitis media, and that it will be cost effective. So that was in September 2017 that they made that recommendation. Their cons were that it would be confusing and maybe hard to implement. But then just last month, they came out and said that they cannot do that because of obstacles that were put forward by the manufacturers of PCV13. And because of that, they said it's kind of like calling that bluff, or kind of said, fine, we're just going to go with 10. We're going back to 2 + 1, 10. And as of May 15th, that's what was supposed to be delivered to all the CLSCs, which is like our public health kind of division of who's doing what. However, before I left, they still haven't received it. So I have no idea if there's a production problem or not, but that is the plan. Now, so the CIQ publishes something called the Protocol of Immunization in Quebec, which is the PIC, which is the Bible for our CLSCs or our public health area that will give the vaccines. And they don't have to have a prescription. If it's written in the PIC, the nurses have the right to administer it. And in the PIC, they talk about high-risk groups. For high-risk groups that I showed you before, it's not a 2 + 1 schedule, it's a 3 + 1 schedule. In what they said in terms of this change going to PCV10 from 13, they talk about high-risk kids over the age of 5 who are eligible should get PCV13, but they do not address high-risk kids under the age of 2 and what to do. And so they haven't come out and written it down that do you give the 13, do you give the 10, do you give 2 + 1, 3 + 1? So that I'm not really sure. So again, Quebec is the same but different. Sometimes it's okay to be different, or sometimes we are asked backward. But really, the CIQ is looking at it with different lenses. Are we looking at this in terms of prioritizing public health dollars versus the individual patient? And what would you do with your own kids? And I always want to put my picture of my own kids in. So this is my firstborn. This is my son who is here now. He got PCV7. I did not go with the 2 + 1. I gave him 3 + 1 because whether he was high risk or not. My secondborn, so this is a perfect family that illustrates what happened in Quebec. She was mixed between PCV7 and 13. And my youngest is all PCV13. And again, I gave 3 + 1 just because I'm crazy. So that's the pneumococcal aspect of the talk. Do you have questions about that?
I guess just about if they're focusing on the dollars, how much of the dollars spent on each patient that gets there's a pneumococcal disease in terms of offsetting the...
Yeah, so they're saying that there's between a $10 and $20 difference per dose.
Yeah, but once they get sick...
Yeah, they don't put that into their equation. I mean, if you talk to a parent once they get sick, it's not worth it. Whether it was $5 million, it doesn't make a difference if that kid is sick. But overall, in terms of, so what they do talk about is that there's 86,000 live births per year in Quebec. If you're looking at 3 doses or 2 doses or 1 doses and you do all your multiplication at $20 a dose, you're saving per year anywhere between $2 and $5 million. And is that savings good enough to justify the perhaps increased number of cases? That probably would be 19A. And that's where the public health dollars kind of come in. All right. So I know I'm kind of running over time, and this next part has a lot of stuff. And what we can do in the interest of time is I can just go to the points that are probably more of interest and controversy and focus on meningococcal B and leave out the quadrivalent and the Y, but it's up to you guys. I'm here. It's whatever you guys want in terms of looking at the overall epidemiology of invasive meningococcal disease. But looking at the time, maybe we'll focus on the B. But that's up to you. It's completely as you want. But regardless of what we do, we can talk very briefly, because I don't know how many, depending on who I'm talking to, the younger population, when I say, have you seen invasive meningococcal disease? Some will say no. The olders will say, yes, I have. But so just to kind of illustrate a little bit, so again, we're all olders. So basically it was Hib, then pneumococcus, and it's really Men B. So the objectives, I was going to go over all the clinical manifestations, the epidemiology and prevention strategies. It's always interesting to have a case, but I don't have to go through this case, but this is a case that I managed in 2001 during our outbreak. It was a 13-year-old who came to the ER in a moribund state. He was seen 20 hours earlier in his family physician's office, diagnosed as having influenza, and may have had influenza. We know, just like with pneumococcus, that it's increased during the winter months. You get viral illnesses, it denudes the respiratory epithelium and may allow for invasion if you are not immune. So he had a normal exam when he was seen in his physician's office. We had two big outbreaks of Men C in Quebec in 1992. There was a Men C outbreak, and Menimmune, so the polysaccharide vaccine, was given to all kids from 6 months to 20 years. Not effective at all in kids under the age of 2. So this kid got the polysaccharide vaccine in 1992, but he was 3.5 at the time. When he presented, he was in extremis already. DIC, neutropenic, hypotensive, had a normal LP. He was started on antibiotics, inotropes. His blood culture group C, grew group C meningo. Family was given prophylaxis, but in spite of maximal support, he died 14 hours later. So this was one of our first cases of the 2001 outbreak. So again, starts with colonizations, and it invades in terms of time from when you get sick to admission. It's always under 24 hours. This kid was seen 20 hours earlier, but the delay seems to be greater as you get towards adolescence. Is that because they don't tell their parents, or because parents aren't as worried because they're older, where parents are much more concerned for their younger babies? When people who haven't seen it or have seen it, when you see the petechiae and the purpura, people will think about it. But not everybody has petechiae and purpura, and the beginning rash may just be macular papular or may not even have a rash at all. And when we look at the epidemiology in Canada, it was only obligatory notification to Health Canada starting in 1985. But in spite of that, you see every 10 to 20 years these outbreaks. This was in World War II. Here is this 1992 outbreak that was driven predominantly by Quebec. And again, data now looking more recently from 1995 to 2001. Here is our 2001 outbreak of C that goes down. But if we're going to talk about B, here's your B, which is really the number one player. With C introduction of a vaccine at 1 year, and then so every province now gives C at 1 year, and boosting in adolescence, whether Men C alone or with the quadrivalent, C has really fallen off. So B is there, and number 2 is Y. And so that also depends on the province. So this is all, I'm going to skip over from the interest of time, and if anybody has questions, then we can come back to it. But this is all about the outbreaks, What I really want to, this slide illustrates the two age ranges where invasive meningococcal disease is more predominant. It doesn't matter, there is cases throughout life, but the highest range is in the first year or two, with the second peak in adolescence. And that's true whether it's C, B, or Y, or any serotype. What we do know with Men-C, 1 dose of 1 year does not last you, that you need a booster. And again, in the interest of time, we won't go through all of that, but every province now gives a booster in adolescents. I understand it's only a couple years ago that BC switched from the C to the quadrivalent. Quebec is the only province that still just gives C. So I'm just going to fast forward. So this is all about the quadrivalent, and if we have time, we can come back and talk about the three different quadrivalent vaccines. There's Nimenrix, Menvio, and Menactra. And if we have time and there are questions, we can come back. But basically, if you look at NACI's recommendations for the quadrivalent vaccine, they say for routine immunization in adolescents, either the quadrivalent or the monovalent C is what you should be giving, and it all depends on the epidemiology. So Quebec says our epidemiology does not warrant that increase in cost. The second recommendation is anybody who is at high risk, any of the quadrivalent vaccines can be used, and different ones got licensure for different age ranges, but Nimenrix has come down now to 6 weeks now. Menvio was the only one that was under a year. Menactra was over the age of 2, but it's basically which one you're going to use over the age of 2. NACI says they're interchangeable, but it's not interchangeable in terms of continuing your series with one or the other, but it's interchangeable in that you can choose one or another. It doesn't really make a difference. Again, Quebec has to be different. We're the only one that gives Men-C. And in the States, there is a big concern about invasive meningococcal disease at universities. And so starting in 2000 or 2001, parents or the adolescent themselves had to sign something to say that they either got the quadrivalent vaccine or they refused it, but there was increased awareness. And then there was the B, and all the outbreaks would be because they had a decent coverage because people had a sign to go live in a dorm and go away to university. So that's where Canada doesn't have any statement about that, about going away to university, but the ACIP does. And I'm going to just kind of fast forward. There's a whole bunch of things about number of doses, but we'll get to the issues of B. And so my experience is, regardless of what vaccine, whether it was Prevnar initially, Varivax, the quadrivalent vaccine, people have tons of questions when you have to pay for it. Once it's a funded program, people stop asking questions. Whether it's the families, for sure, they're not necessarily know enough to ask the appropriate questions, and the physicians again will go with whatever is funded and paid for. And there's much more time spent on discussing vaccines that are not funded. And at the present time, with the exception of Quebec, which we were transiently funded a Men-B program, nowhere in Canada is a Men-B program funded. So that's what generates a lot of questions. So we'll talk about to be or not to be in terms of vaccine. So what most people want to know is it a good vaccine? Is it a safe vaccine? If it is, how reactogenic is it? And who should I give it to? And how many doses should I give? And so when you look at epidemiology across Canada, This is from 2013, so a little bit out of date, but not so significantly different. This pie graph over here is overall the national averages, and you can see that B accounts for more than half, and Y is the next big slice. When you look at Quebec, the overwhelming majority of this, so everything that same color for each province, B is the majority. Come out here to British Columbia, B and Y look almost similar. And so you understand why people will have gone, or the province will have gone to your quadrivalent booster because of the issue of Y. And with very little Y in Quebec, you can maybe understand why Quebec doesn't support the quadrivalent. So again, all the outbreaks that has happened in Quebec. So we can talk about the Men-C, but really what has happened recently is that in 2014, in the Saguenay-Lac-Saint-Jean region of Quebec, there was an outbreak of Men-B. And if we look overall in Quebec, this purple bar is your Men-B of the total bar. Here's your 2001 outbreak that we had, the yellow being C. But basically, just graphically looking at this, you can see that everything is purple in the more recent. It's all B. And age, yes, is an issue of mind over matter. If you don't mind, it doesn't matter. But because of the same epidemiology of increased risk of infants and adolescents, age is very important of who you are going to vaccinate and at what age. And if you look overall, this is all serogroups. This is serogroup B. These lines are by age. And so the top one that has the highest incidence is in kids under the age of 4. The next kind of turquoise one is your adolescents. So again, graphically, another way of illustrating that the highest risk are young kids and adolescents. So in terms of the Men-B vaccine, there's been problems. Why it took so long is that basically it mimics neonatal neuronal tissue. So the body may not, the polysaccharide part of the Men-B itself mimics neonatal neuronal tissue, so it didn't mount a decent response. If it did mount a response, there was maybe some cross reactivity, and was not an effective nor thought to be safe vaccine until different technology came around in terms of Men-B. Everything else is your polysaccharide part of the vaccine conjugated to a carrier protein. When it comes to Men-B, it's different. So there are 2 licensed vaccines available in Canada. The more recent one since October of last year is something called Trumenba. So again, to be appropriate, I should be not giving trade names, but the actual, when you look at the ACIP, it becomes very kind of confusing. It's all FHBP2 or something in terms of the Trumenba, which is your factor H binding protein bivalent for your Trumenba, and your 4C Men-B is your Bexsero. The C has nothing to do with serotype C. It's 4-component Men-B. That's what the acronym is. But so I apologize. I shouldn't be giving trade names, but from this point forward, we'll stick with trade names because otherwise it's too confusing. So we have, since October 2017, we have Trumenba. Since 2015, we have Bexsero. There are no studies, at least that I know of or I could find, that directly compares one to the other. But they do have their own studies about reactogenicity and side effects. So what are the side effects? So the big thing with Bexsero was the issue of fever and tolerability, that it was very reactogenic. Fever is what people kind of focus on. So that's this bar over here. And that when this darker blue bar is looking at Bexsero with your routine vaccines at 2, 4, and 6. And you can see that the incidence of fever is somewhere between 40 and 60% when you combine it with routine. When you look at routine alone, which is this purplish bar, what I find surprising is that it's 15 to 20%. And my experience, and I'm not a primary care pediatrician, but what I understand is that in the days of the wholesale pertussis, we always gave acetaminophen because we expected fever. And with our newer vaccines, people aren't necessarily saying to give the acetaminophen. Some do, some don't, but they don't get calls because of the fever. So I was really kind of surprised in terms of in this study for routine alone that 15 to 20% actually had fever. So for Men B alone, it was between 20 and 40%, up to 60% if you combined it with routine. Same degree of fever with the adjuvanted H1N1. But they found high in routine. But the big thing is that these are studies from Europe where they use paracetamol, which is basically the same compound as acetaminophen. And basically this incidence of fever post, that's what the PP is, post paracetamol, and no prophylactic paracetamol is the NPP, decreases dramatically. The different colors in these bars is your height of fever. So over 40, which will make most people concerned, really comes way down. So the recommendations, regardless, is to give acetaminophen or paracetamol with the Bexsero. What about the effects of an antipyretic? There was always a concern in the old days of the wholesale pertussis that if you gave acetaminophen, you dampen the fever. Will you dampen the immunogenicity that goes along with it? That never was really borne out, and I can show you all the data, but basically there was no impact if you gave that with the Bexsero, with the exception of serotype 5, I think, in Prevnar 7 was lower. What about adolescents? So this I find so interesting. So again, if we look at fever, this last bar is your placebo. So your placebo in almost everything, so that's, they're still getting an IM injection, all the adolescents, whether they get IM saline or Bexsero, they all have malaise, myalgia, arthralgia, headache, nausea. So, and that's so subjective. When you look at swelling, it's interesting, it is lower, but I guess you still will have some degree of swelling if you're going into the muscle. But if you're focusing on fever and fever over 38, it's really not as impressive as it was in the infants. What about Trumenba? So here, this is 3 different things. There's pain, redness, and swelling. And the first bar is Trumenba, and their control was the hepatitis A vaccine. So again, you're giving a vaccine into the muscle. You're going to expect some pain and some redness and some swelling. I think that that just goes for any intramuscular vaccine, but it is higher for Trumenba than it was for hepatitis A. And what about fever? Again, the numbers, now Trumenba is only licensed for adolescents. So this is not, there is no data on the infants. But when you look at the adolescents, it's very similar to Bexsero, anywhere between 1 to 5-6% will have fever. So no head-to-head comparison, Bexsero to Trumenba, but overall, when you look, the reactogenicity looks very similar. So if you're going to give it, how long will the protection last? And how many doses do you have to give? And the problem with whether it's invasive pneumococcal disease or invasive meningococcal disease, it's different than measles, mumps, rubella, varicella, where your incubation period can be 1 to 2 weeks. And that if you are exposed and you have memory cells, you have time to ramp up your production of antibodies and protect. For invasive bacterial disease, the incubation period can be as short as 1 to 3 days, which I showed you for the pneumococcus, and definitely true for meningococcus. So there is this belief that you always have to maintain a protective level when it comes to the invasive invasive bacterial disease versus the viral. But how long will it last? How many doses do you have to give? That's hard to know. So when there was a systemic review and a meta-analysis, basically they said there's an acceptable short-term safety profile, a good immune response within a month of vaccination, but a booster dose is going to be required. How often, at what age is to be decided. So like other vaccines, the waning immunity. So what are the recommended dosing schedules? For Bexsero, in Canada, it is licensed for babies starting at 2 months to 17 years. In the States, Bexsero is licensed for the 10 to 25. So different age licensures. So therefore your dosing is going to be different in the States than here. For infants, it's 2 or 3 doses. I'm going to say why I'm saying 2 to 3. It's coming back to that concept of 2+1 or 3+1 that we talked about for pneumococcus. The vaccine insert started all with 3+1. The UK, which was the first country to adopt a funded program, went with 2+1. Quebec, when they're saying to give it in infants, they're going with the 2+1. It's hard to actually measure the outcome for a disease that is so infrequent. And that's part of the problem. So the 2+1 is 2, 4, and 12. 3+1 is 2, 4, 6, and 12. In terms of adolescents, there are different studies with Bexsero that looked at 0 and 1 month, 0 and 2 months, 0 and 6 months. And basically they're all relatively equivalent. So the recommendation is 2 doses anywhere between 1 and 6 months. For Trumenba is only indicated for 10 to 25-year-olds. Is it 2 doses or is it 3 doses? They say that for routine protection, 2 doses is fine. In a high-risk situation, in an outbreak situation, then it should be 3 doses. So if it's 2 doses, it's at least 1 month apart. 2 doses, it's at 0 and 6 months. If it's 3 doses, the first 2 doses is at least 1 month apart, followed by your 3rd dose 4 months later. You can give concomitant vaccines. It's been studied with Trumenba. If it's an adolescent vaccine, what am I doing with my HPV, with my quadrivalent meningococcal vaccine, the other vaccines that we're giving? There's no problem with your Adacel or your Boostrix. There's no problem in terms of immunogenicity. You just can't mix them in the same syringe. It would be nice to give 1 needle. So what are the real life experiences and to know if it's safe or not? And that really comes from the university outbreaks of MenB, where it has been used on large scale. So when you look at the MenB outbreaks occurring in the States, there are multiple university outbreaks. There are 2 that have come to the forefront. There's Princeton and Santa Barbara. In Princeton, this is from Princeton itself, and it shows you the 9 cases that happened and all the interventions that they tried to do to curtail it. So first they started with a big thing with why is it increased in adolescents is that they like to share. Maybe they share notes in school, but they share body secretions, they share cigarettes, they share joints, they share drinks. And in terms of trying to curtail the outbreak, they tried to go with a hygiene campaign and putting up posters in dorms, dedicated websites, posters in dining rooms and dining halls, and basically saying don't share. But that doesn't really, you can put that up, that doesn't stop them from wanting to share. And the only thing that really helped in the initial part of the outbreak was summer. People left campus. And that obviously curtailed it until they came back. Until they came back. And after 3 more cases after they returned, they intervened with a vaccine program. In terms of the Santa Barbara, there were very limited number of cases. There were only 4 cases, but 4 cases in 2 weeks. They all lived the quote unquote Greek life. They were either part of sororities or frats. And all this outbreak happened after a Halloween party at a frat. And you can only imagine what normally happens at increased frequency at a Halloween party. So they started off with giving prophylaxis and then curtailed the outbreak with the vaccine. And so basically these 2 outbreaks happened before Bexsero or Trumenba were licensed, but then they got fast-tracked so that they would be able to use, and they were very effective in curtailing the outbreaks. So the CDC recommended that both vaccines can be used in an outbreak situation, 2 doses for Bexsero, but because it's an outbreak, it's 3 doses with Trumenba. Whatever you start with in those 2 or 3 doses, you should finish with. But they do not give a preference of choosing one or the other. Just once you start with one to finish with that. Closer to my home, but not necessarily your home, is that outbreak in the Saguenay-Lac-Saint-Jean region. Again, just giving a visual illustration of the number of cases of this Saguenay-Lac-Saint-Jean versus Montreal. And because of that, in April 2014, Quebec started with a funded program at 2 months to 20 years of giving everybody Bexsero to curtail the outbreak in that region only. Now, what's interesting, if I go back, is that the capital was the next most frequent, and I was expecting there to be an outcry where all the politicians live, but it did not follow through within the capital. So they gave everybody 2 months to 20 years with the reason that the incidence was higher than the rest of Quebec, with a higher mortality rate and sequelae thereafter. Most importantly, Bexsero, which is what they used, covered the strain that was circulating. And that really is a very important part, because there is this question that Bexsero only covers 66 or 2/3 of the strains in Canada, where Trumenba will have upwards of 85 to 92% coverage. But it doesn't make a difference if it's covered. In an outbreak and you know what that serotype is, you can choose what it is. When you're giving it for the general population, there will be this trend to say, well, if it only one covers 2/3, the other covers 85 to 90%. But there's no head-to-head comparison. It's all an extrapolation of what will happen. So in Quebec way, they do something and then they study it and they publish. So they looked at what were the reactogenicity. Overall, this was given 2 months to 20 years, so higher in younger kids than in adolescents, but overall 10% had fever, 6% missed school or work, and 1% sought medical attention. And when you look at the fever, that 10% again splays out based on age. Higher for the infants, lower for the adolescents. Again, number of doses of antipyretics that were needed, but it brought down fever. And when they looked at the 2 doses, basically the side effects seemed to be higher with post-second dose than the first dose. Not statistically significant, but across the board for each thing, whether it was fever, pain, redness, etc. So what are the official and unofficial recommendations out there about what to do with MenB? So in the UK, they are the first place that have instituted a national program. They have gone with the 2+1 option, not the 3+1 option. And they recommend 3 doses of paracetamol with 1 at the time of vaccination and 2 further doses at 4 to 6 hour intervals. And they had very good uptake. 97% of eligible babies received the first dose and 90% got the second dose. And they say that there was a 50% decline in the vaccinated population of MenB with that introduction. And again, just different ways of looking at it. What's interesting is when they introduced the Men B in the UK, they kind of got very lax on their Men C program in infants. And what you can see from 2016 to 17 is that their Men C number went up. And that is probably good enough, because people will say, why are we still giving Men C? We don't see it, but we still give it at 12 months. We're boosting it in adolescents. And this is just an example that if we stop doing that, it doesn't mean that it's not going to come back. And what they did do at the same time as they kind of fell off on the Men C is they went in with a quadrivalent vaccine program. And by doing that, you can see that their W and Y dropped off. So they did different things at the same time, but that's the UK. They had, so basically, they had no safety concerns, and they recommended the 2 doses with the prophylactic paracetamol. So what do smarter people than me have to say? NACI, so first the CPS said pending NACI, it could be offered to high-risk people. NACI did a very different NACI kind of statement. It's not that traditional NACI statement. They did this advisory committee statement. It's a literature review more than anything else. And their recommendations were the following: that it can be considered on an individual basis for anybody over the age of 2 months, but there's not enough evidence to recommend routine vaccination for the Men D. For the reason that we already talked about, estimated coverage of 2/3 only, high rate of fever, if you kind of roll it out to everybody, what will that really translate to? And the uncertainty of the duration of protection. Should be considered for people who are at high risk of invasive meningococcal disease over the age of 2 months. Asplenix, there's eculizumab, which is one of the biologics that targets the terminal complement, and terminal complement deficiency puts you at increased risk for invasive meningococcal disease. Consider it for prophylaxis, so the vaccine if there's an outbreak, so that we've seen with the universities and in the Saguenay-Lac-Saint-Jean region. Routine use of prophylactic acetaminophen. What do I suggest? So I would recommend, so remember, Tremenba is not licensed for infants, only Bexsero is. So I would recommend Bexsero for the infant population. Once I'm doing that, I would follow the UK and go with the 2+1. That's just what I tell my friends who are out in practice. I would recommend the Men B vaccine for adolescents, and it could either be Bexsero or Tremenba, either or. There is this notion that maybe Tremenba will cover more strains. For an incidence of disease that's lower, I think either is fine. What age in adolescence should you give it to? I'll tell you what I'm doing with my own kids. But in terms of what about all the other age ranges in between those newborns and the adolescents? You know, parents will come in and you say, oh, you're giving it to my 16-year-old. What about my 13-year-old? Why aren't you giving it to my 13-year-old? And do I have to wait until they're 16? I'm not adverse to giving it at other ages, but I don't think that the epidemiology really warrants that. And I don't know how long the protection will last. And that will you have to give them yet another dose or 2 when they reach adolescence. So what do I do with my own kids? I basically decided that so you guys go to grade 12. We go to grade 11. So I decided grade 11 is when I'm going to do it. So my son is in grade 11. He's in grade 11. She's in grade 9, and she's in grade 6. He's going to get it. But he wasn't very happy with me. And I opted, because he's got a girlfriend and they spend too much time alone, to go with the HPV vaccine. And I'll fight my battles one at a time, and then I'll do Bexsero. But that was my plan, was catch him at grade 11 before he goes away to university. Again, from that university perspective. And just to end off, Yes, it's called reading. It's to install new software in those brains of young kids. But with that, any questions? Those are not my kids.
How much is the per dose of Infectious?
I think it's about 120 to 150 range. I'm not sure exactly. Do you guys have any idea of cost?
And then if you want a month later, right?
So Bexero for adolescents, it's 2 doses anywhere between 1 and 6 months. So it's somewhere in that range, like that 120 to 150. And Trumenba is how much? Sorry?
This price is 102. Probably more than that in the pharmacy.
Right. So I think that they're probably somewhat comparable in terms of price. It's not cheap.
It's NAS, so you said 9 minutes is down to 6 weeks. Was NAS come up for that?
I don't know.
Not yet.
No, the NACI statement is still the last NACI statement in terms of the quadrivalent. I have it here. Oops. Again, is a little outdated. It's from 2014, I think. Yeah, so they said under the age of 12 months, use Menvio, 12 months and older Menvio or Nimenrix, and over the age of 2, any of the above. That was the last NACI statement when it talked about the quadrivalent vaccines. Any questions from Vernon or elsewhere or else?
Do you ever recommend the quadrivalent meningococcal for babies who are obviously traveling?
If they're high risk, in terms of asplenia,
Yeah, of course, but just for
but
typical.
routine, I don't. And what I did for my own kids, where Quebec only pays for C in Sec 3 or grade 9, is I gave them the quadrivalent. Covering once they're getting the needle wide. I don't necessarily, so I had to pay for it. It costs, I just got, it was $130 for my daughter who's in Sec 3. To me, it was worth it versus Nancy alone, because I don't know where she's going to go away. And
That might have answered my question. My question was going to be, it's probably just ignorant, but my question was going to be, Men C is what we give now, right?
so we give Men C at 12 months.
2 and 12 here.
2 and 12 here?
Well, and to give Men B, so to speak, we'd have to give it a whole different vaccine, or is there a vaccine that combines the two?
No.
Oh.
Wouldn't that be nice? They're very different.
That's what we need.
They're very different. It would be great if you had the quadrivalent and Men B kind of together. They're very different technologies. There's will a company that makes both come out with something. So again, so Pfizer makes Nimenrix and Trumenba, but Trumenba is only licensed for adolescents and not for your babies. And so I don't know if that's coming anywhere in the near
GSK is
future.
working on a pendant.
Because it's hard to, when you give, 2, 3 shots or whatever, it's hard to say, well, I'm going to give you another one.
Yeah.
It's like
And
they'd be
so
against that.
there's
somebody else.
Prevnar 13, there's the Men B. So I don't know. I didn't realize that you gave also at 2 months. I thought it was Alberta. Alberta initially was the one that was giving it 2, 4, 6, and then 12, and then dropped down to 2 and 12. I didn't realize that BC stuck with that. There is that whole concept. So in Quebec, where it started with the Men C program in 2001 was because of the outbreak. The number of doses was based on your age. If you started at 2 months, you needed 2, 4, 6, and 12. You started at 4 months, you only needed 2 doses at 4 months and 12 months. And then they said, let's take advantage of the herd immunity. That again, that same concept of coming back to the invasive pneumococcal disease of that 1+1. If you have a robust program and herd immunity, that's the time to intervene and just cut down the number of doses. And we went to 12 months, and I thought it was every province except for Alberta, but I guess not. So I don't know what's
I just have a question, certainly representing BC. Is there any public information about Bexaro that parents who aren't in the infectious disease world or physicians would run across it just reading about newborn care, for example?
They could search that BCCDC, that there's patient and parent information on the website, and also
So it is.
BC Pediatrics, we have the handouts too, providing all these vaccines.
It's there. It's there.
Well, thank you very much. It was